Sir, we are live now. With all your permission, I am starting this session. Good evening, everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, none other than Dr. Ashok Kumar Das, sir. Sir has done MBBS, MD in Medicine, PhD, TNB, FAMS, FICP, FRCP, and consultant physician and endocrinologist at Pondicherry Institute of Medical Science, PIBMS. And today he is going to discuss on a topic, role of metformin in women's health. Let me tell you overview of the topic. Metformin is a medication traditionally used to manage type 2 diabetes. However, its therapeutic application have expanded beyond diabetes, and has shown potential benefits in various aspects of women's health, such as PCOS, gestational diabetes, etc. To know more about this topic, I would like to invite sir and hand over this session to sir. Sir, from here, stage is yours. You can proceed now.
Dear Mr. Faraz, thank you very much for this very kind introduction, and my thanks and greetings to entire team at the IJCP, Nilesh ji, Nishit, and all of you who have organized this, and I'm delighted beyond measure. And most important, I would like to greet the large number of audience who have joined this program today, and I will strive my best not to disappoint you. Dear friends, suffices to mention that what is most important thing in the world today is the women's health. It has been said that if we have just concentrated upon the women from 1947, today we would have been a different nation. It has been also said that the best man for any job is a woman. With this much of introduction, I'm going to put before you my thoughts, my ideas, the evidences from the robust scientific data that how the metformin is a wonder drug. Your drug, metformin, was discovered in the French lab long ago. And I'm in Pondicherry, which is a great French connection. I went to see that lab where the metformin was discovered. Because today, metformin is the foundational drug. Please remember, metformin is the the first drug. In metformin is a drug which can be used with any other drug. And it has been also said that metformin is the molecule of the decade. Therefore, dear friends, I'm delighted to present before you role of metformin in the women's health. Dear friends, to make a long story short, metformin is used extensively in a condition called polycystic ovary syndrome. I must tell you, dear friends, today polycystic ovary syndrome is rated as the most important contemporary challenge. You know why? Because in the 25 years age group, the prevalence is almost 40% of the girls and ladies, and it occurs at very young age. And number two, with the acculturation, with the civilization, with the Coca-Colaization, with changed lifestyle, the PCOS has become a great malady in our country. So we'll discuss that. We'll discuss about metformin in the known diabetics, those who are type 2 diabetics already existing, how we can use metformin in them, known diabetic. Also, we'll very importantly discuss how metformin is a drug today emerged as a very important drug for the treatment of what we call gestational diabetes, the diabetes which occurs during a lady's life when she is pregnant and disappears after 6 weeks. So metformin GDM will discuss. We'll also discuss today, my dear friends, metformin in the women's cancers. I will concentrate upon the breast cancer, very great malady. I'll also describe other women cancer where metformin has been of great use. And finally, I must tell you that metformin today has been rated as an anti-aging drug against the age-related comorbidities. it makes you remain young. So we'll discuss all this in next 45 minutes. Dear friends, most important thing to mention that in the recent paper of ours was published on the 7th June, the ICMR India last paper, you will find that the prevalence of diabetes is rated at about 11%. And with that, the known diabetics today in our country is 102 millions, no more 72, 102 millions. But my dear friends, mind you, the prevalence of pre-diabetes, that's a condition through which every type 2 diabetes passes, is about a whopping 15%. I will hasten to add the prevalence of diabetes in the cities 11.1, but in the villages it's about 9.9. But as far as pre-diabetes, the precondition of diabetes is concerned, it is equal. It is 15% in the urban areas and 15% in the rural areas. Is a Lancet endocrine paper published 7th June. And this has made us to realize that we have to stop this pre-diabetes marching onto diabetes. And Metformin is the drug of choice for treating pre-diabetes, passing on to diabetes. And I must tell you, pre-diabetes is much more in the women. And Government of India, DCGI, has approved about 1 year back Metformin as the drug of choice, next to lifestyle, of course, as the first drug to be used for preventing pre-diabetes going to diabetes. Number two, it has been told Metformin is hailed as a drug which is 2-in-1 drug. That means it has a metabolic effect and also cardiovascular effect or vascular effect. And I must hasten to add here, as you all know, that the ladies have some immunity against heart attacks, against coronary artery disease, but that lasts only up to menopause. Beyond menopause, this immunity is lost. And Metformin works out as a very cardiovascular friendly drug, both in the premenopausal and the postmenopausal women. I want to say this, that the number of heart attacks, number of heart failures, number of specific heart muscle disease in diabetes, what we call cardiomyopathy, name of the quantity of intermediate syndrome, angina pectoris, is much higher, much more higher in the female population than the male. And Metformin is a wonder drug for the cardiovascular benefit. Dear friends, we know that when you have to induce pregnancy, we use a drug called clomiphene citrate. That's the number one drug, no doubt about it. But the people who are resistant to clomiphene citrate, where clomiphene citrate does not work, the Metformin has stood out as the number 2 drug of the ovulation induction agent. So it's used too much for the ovulation induction. Of course, second to clomiphene citrate. Beyond this, it has a lot of immunomodulatory effect, like reducing inflammation. And it reduces in the females the late miscarriage. The miscarriage which occurs beyond 5th month is prevented by this drug. It also prevents the preterm delivery of the fetus. So dear friends, these are some peripheral benefits I want to tell you first. But the two areas where the metformin is used, left, right, and in the center, and the polycystic ovary syndrome and GDM. Let us take up one by one. Now, why it is used polycystic ovary syndrome? Because of its mild anti-androgen activity. It is an anti-male hormone activity. Therefore, it is used in the polycystic ovary syndrome. It reduces, as I showed some time back, not only late, but even early miscarriage. It has been said that it provides a shield against miscarriage. If somebody is on metformin, the abortions are much less. I told you, second line ovulation induction agent. Dear friends, please be aware of a syndrome called OHSS. I'll make it simple for you. It's called ovary hyperstimulation syndrome. You know, during IVF, when we try to help the infertile couple by the in vivo fertilization, we give lot of hormones by injection that produces hyperstimulation of the ovary. And there occurs the swelling of the ovary and severe pain. Believe me, dear friends, all over the world, this drug has been used as the drug of choice in the ovary hyperstimulation syndrome that occurs with IVF treatment of too much of female hormones to induce eggs Therefore, this is a wonderful drug for that also. Now coming to GDM, what are the highlights? Reduces weight gain. There are two drugs in the entire history of diabetes where the weight gain is reduced. One is this drug, other is probably the incretin drugs. So this reduces weight gain. Most important, metformin is AAAA. It is an affordable drug for the female disease. It is an appropriate drug for the female disease I'll show just now. It is available and is accessible across pan-India. Now, it is a safe drug, it's an efficient drug, and it's very much acceptable because, in our country, people do not accept insulin, even though it is a good choice for the GDM. Metformin is no less. Today, we are not giving them a choice. We say them that if you are trying to metformin is well and good, and therefore the treatment is started immediately. So its efficacy, its acceptability, its safety is same as insulin. And it provides less miscarriage and decreases the neonatal hypoglycemia. See the benefits. Dear friend, this is an yellow book, which you see on the left side. This yellow book was brought out by us. This is a second edition. This is the only book which ministry has brought out about the medical management of the GDM, medical management of the GDM. And it has talked about the oral anti-diabetic drug, metformin and insulin in the females having GDM. It says that metformin can be started at 20 weeks of pregnancy, because first 16 weeks, this drug can be secreted through the placenta. So we start it on 16 weeks and beyond. And we start it in all the cases where the medical nutrition therapy, the nutrition therapy, the lifestyle comes as number one. But I must tell you, it's very difficult to adhere to nutrition. Very difficult to control everything with nutrition alone. It's a good help, but not enough. Therefore, we always add after 15 days, 3 weeks, metformin at the beyond 16 weeks. And when the blood sugars are not controlled in a pregnant female. If the metformin dose we start is 500 milligram twice daily, and we can get it up to maximum 2 grams a day. And if it is not enough with that, then we add insulin. Now what happens? Why this is the preferred drug? Number one, in GDM, the drug has to be taken for at least 9 months, 10 months. So it is very convenient to take a tablet than insulin. Number two, there is less weight gain. And weight gain is a bad thing in pregnancy. Number two, the acceptability, the smoothness of control is possibly better than insulin. Now, if you would need insulin very high doses, some of the ladies have very severe insulin resistance in GDM, and the dose of insulin we require is very high. So if the dose required is very high, if we add metformin in the treatment, the requirement of insulin comes down. And at the PSC, primary health center level, the medical officers should initiate treatment and refer pregnant women with GDM to a higher center. So the moment detected by a simple DIPSI test, post 75 gram glucose, blood glucose beyond 140, the moment it is tested and you find this, you can start on metformin without waiting for the insulin, then you can refer to any other center. Therefore, if you control early, metformin also is a wonderful drug. Now, the metformin acts at each stage of the PCOS syndrome and produces improvement. Now, it acts in the stage of insulin resistance. Metformin acts at each stage in women PCOS by improving insulin resistance. Number one, if there is menstrual cycle which are irregular, if there are in cycles which are anovulatory, PCOS patients who are undergoing IVF, the in vitro fertilization, PCOS patients will become pregnant, and metabolic dysfunction in PCOS and type 2 diabetes mellitus and metabolic syndrome rightly said that PCOS is a younger brother of metabolic syndrome. So therefore, at each and every stage, the metformin is immensely useful. It improves menstrual irregularities and reduces because anti-androgenic property reduces the excess hair growth which occurs in the PCOS. It improves ovulation and increases pregnancy rate, most important. Prevents ovarian hyperstimulation syndrome and increases the live birth because it provides a shield, a protection to the fetus, to the embryo. During pregnancy, it significantly reduces the miscarriage rate and reduces the risk of lady becoming GDM, gestational diabetes. And metformin improves dysglycemia and other parameters, other facets of the metabolic syndrome. Dear friend, today metformin also has been used in cancer. Believe me, dear friends, in many female cancers, will confine myself to female cancers today, this drug has done wonder. You know, when you give metformin orally, it goes to GI absorption. After that, goes to portal circulation, goes to liver. It hepatocyte, it reduces the OX and energetic stress, decreasing neoglucogenesis, decreasing glycemia, decreasing hyperinsulinemia, decreasing hyperproliferation of the insulin. And therefore, this decrease in the proliferation of insulin-responsive cancers is a great gift of metformin. Now, on the cancer, reduces the OX and the energetic stress. This anti-neoplastic action of metformin are in few cancers like LKB1 status, complex 1 mutations, and with co-treatment such as oncogenic kaizen inhibitors. To make this story simple, in breast cancer, in the cancer of the uterus, of the endometrium, in the ovarian cancer, this drug has been used apart from being used for the colonic cancer. So this has also stood out today as an anti-cancer agent in both males and females, but females are more. I have described about the female cancers it works with. This is a beautiful article, a population-based study, metformin use and the endometrial cancer. See the benefit in the endometrial cancer. Metformin also used in the early breast cancer, a prospective window opportunity for the neoadjuvant therapy. And you know, in one of the articles published, diabetes, metformin, and breast cancer in the post-menopausal women, the effects were so great, so profound. It was called promising clinical practices of metformin in women with PCOS and early stage endometrial cancer. It has emerged as one of the drugs of choice. And also, there is unparalleled evidence of metformin use in women's cancer over the years, over the many years. Therefore, dear friends, how metformin works and how does it work as an anti-aging property? I told you that metformin makes you young. You do not become old very early. Now, one of the uses of metformin is the modification of the gut microbiota. You know, today, whatever you take diabetes, take hypertension, take infectious disease, take colonic cancers and all that, they are all mediated through gut microbiota. You know, in our gut, there are microbes. They are helpful microbes. Now, this drug produces reduction of the cell growth and cell proliferation and protects against the proteins and lipids and most important DNA damage. Therefore, the reduction in the oxidative stress, reduction in the endothelial dysfunction, therefore enhanced mitochondrial biogenesis and autophagy, giving rise to the cellular senescence. Cellular senescence means the progression of the age. Because of the mechanism I described before you, like the gut microbiota action, cell growth, proliferation action, action against protein, lipid, and DNA, reduce on the oxidative stress and endothelial dysfunction, there is enhanced mitochondrial biogenesis and autophagy, so there is decreased cellular aging, decreased cellular senescence. It has got it enhances insulin sensitivity, is anti-resistant, insulin-resistant drug. It reduces the hyperglycemia and the ages, the advanced glycogen end products. It ameliorates lipid metabolism and reduces inflammatory response. Wonder drug. Therefore, dear friends, people have said, as diamond is a friend of the lady forever, metformin is also a friend of young ladies, old ladies, age ladies, all age groups forever. Dear friends, I like to little more detail on this particular PCOS, which is one of the most, I called it most important contemporary challenge. I'll go in little more detail. Now, this is a cartoon which is beautiful, which I found in the Wellcome Library. Now, you know, long back, but now it must have come to books also. Now, this particular projection shows how in each stage of the lady's health, each stage, from in utero to old age, how this particular drug affects and produces polycystic ovary syndrome. Now, in the before birth, it can produce intrauterine growth reduction and also small for gestational age. So the baby born to the PCOS mothers can be IUGR, growth retarded, and can be small for gestational age. Now, when the child little grows up, the patient has insulin resistance. You can make out the chubby child. She has lot of adipose tissue, excessive postnatal catch-up weight gain. You know how much weight gain she has got. Premature adrenarche and premature puberarche. That means she gets menarche much earlier, and therefore this is a bad thing to happen. Now, in the middle age, the patient develops lot of weight excess. There is visceral fat accumulation, irregular menstrual cycle. There is anovulatory cycle, so therefore infertility, acne, seborrhea, and hyperandrogenism and hirsutism. Little later, towards beyond middle age, around 50, 55, it produces obesity. It can give rise to carbohydrate intolerance, giving rise to type 2 diabetes, dyslipidemia, of course, to infertility and pregnancy complications. And in the very elderly person, the polycystic ovary syndrome can produce dyslipidemia, cardiac problem, and the problem of cardiovascular system. Therefore, dear friends, the drug which acts on this acts on all the stages of the polycystic ovary syndrome in a female's life. Now, it's a comparison between the PCOS we have in our country and that happens abroad in the other part of the globe, in the Caucasians. And I'll show you how metformin is much more useful in Indian population than compared to the other population. And metformin is very cheap. Number one, the clinical manifestations, especially the insulin resistance in the polycystic ovary syndrome among South Asians, if you compare the Caucasians, there's a great difference. Number one, our ladies get it very young, mean age 26 plus minus 4. Abroad, it is 31 plus minus 5. Now, the age at menarche in India is 12.9, same thing there, 12.8. Birth weight is about 3.5, they're 3.46. So number two, the number of periods per year, the menstrual cycles are so irregular, one gets about 5 cycles, irregular cycles per year, and same in the Western population. The age of onset of the menstrual irregularity is 2 years earlier than their Western counterpart at 16 vis-a-vis 18. And age of onset of hirsutism is 3 years earlier. They get hair. Hirsutism means growth of hair in unwanted places. This happens 3 years earlier at 18 compared to 21. And you know, the infertility is of a longer duration, and secondary infertility even still longer. In 47, the infertility was lasting up to 25 years, whereas only 10 years in the Caucasians. And spontaneous miscarriage occurs much more in the South Asians compared to the Caucasians. So they have much more miscarriage. So that is the difference between the type. So South Asian PCOS presents at a very young age, at least 4 years younger. This is statistically significant and produces a lot of disadvantage. Now look at the BMI. I want to make one point clear. Now PCOS occurs usually in the obese females. But what I have shown here, that compared to the Caucasians, our girls, our sisters, our mothers get PCOS at a lower BMI, at least minus 6.1 kg per meter square lower. That means very much lower BMI, they get PCOS. That means they need not be very fat to get PCOS in our country. The cartoon shows that in the Caucasians, the mean BMI amongst PCOS is about 32.4. Lo and behold, in the South Asians, the mean BMI at which PCOS occurs is 26.3. That is exactly 6.2 low. Therefore, they get PCOS at a lower BMI, please remember. Number two, if you look at the fasting plasma insulin, you will find the Indian PCOS have lot of fasting plasma insulin, meaning thereby lot of insulin resistance. I will try to tell you one point, that we as a nation, so what I'm describing to you is the metformin for the women's health, the state of the nation. What I'm telling you, the all India data, state of the nation. You will find that the Indian PCOS, the fasting plasma insulin is about 90. Caucasian PCOS, the fasting plasma insulin is only about 48, 49. Half, less than, almost half. Therefore, South Asians have significantly higher mean fasting insulin level compared to Caucasian, which is not good. High insulin level can produce a lot of problems. Number two, there needs to be a little different approach to the PCOS and its diagnosis management in our country, and also looking at the long-term consequences of the polycystic ovary syndrome. Now, the women with the non-Caucasian ethnicity might need a different type of management. Therefore, the South Asian women should have an oral glucose tolerance test in spite of their obese or not obese, in spite of the BMI. Abroad, people do not do oral OGTT unless the lady is obese. But in India, we have found that even at a much younger BMI, one gets the whole facet of PCOS. Therefore, we do glucose tolerance test left, right, and the center. And the women of non-Caucasian ethnicity, but South Asian women, should have an oral GTT regardless of the BMI, in view of the fact their propensity towards developing PCOS. Dear friends, what I have described you part of the women disease against which metformin works is only tip of the iceberg. I have told you about hirsutism, hair over the face, hair over the forehead, hair over the upper part of the body. There is acne, too much of acne, and there is infertility. But lo and behold, what happens below the iceberg? If you look at the iceberg, PCOS is a perfect symbol of an iceberg. This is only visible to us. But below this, these ladies, they carry a very high cardiometabolic risk. They have very severe dyslipidemia. This is also the finding in the in-depth study published on 7th of June, our paper. They have also glucose intolerance, and they have increased inflammation. So dear friends, remember this, in addition to the three I described, they also have increased cardiometabolic risk, dyslipidemia, glucose intolerance, and inflammation. Dear friends, therefore we say in the PCOS, it is more than meets our eye. Very important. Now, you diagnose PCOS as an exclusion diagnosis. It's a constellation of symptoms like acne, hirsutism, other signs of hyperandrogenism, amenorrhea, and infertility. However, please remember, there are so many common diseases which can mimic this disease, PCOS, like hypothyroidism, hyperprolactinemia, non-classic CH, congenital adrenal hyperplasia, Cushing syndrome, hypogonadotropic hypogonadism, and androgen secreting tumors. All this can produce, but metformin is numero uno. In the adolescents, the PCOS is a diagnostic challenge because routine during puberty, acne, irregular menstrual cycle, it is difficult to say whether this acne and irregular menstrual cycle, no lady in the beginning is very regular. An irregular cycle, whether it is a pathological or normal process. Number two, we do not do ovarian imaging in the young people, adolescents, because of to avoid the irradiation. It's not necessary. So since you do not do irradiation, do not do the imaging, sometimes become difficult to diagnose in the young females this particular disease. Therefore, the 2018 guideline, the international guideline, which is evidence-based, said that let us recommend the diagnosis from history rather than the current. If there's a past oligo means less, oligo-ovulation started, that means lady is infertile, there is less periods due to menstrual cycles becoming less regular in perimenopausal age. So two situations. In the perimenopausal age, the cycle becomes much irregular. On the young age, when there's a current oligovariant, very minimal spotting of blood only, not pure menstruation. And there is a oligo, there's an infertility. One can think of in the adolescent PCOS. The guideline also suggests evaluating women's history of PCO morphology and assessing ovarian morphology using S-specific criteria for the ovarian follicle numbers, which decrease with women's age. The classical features of the PCOS that occurs in the female are menstrual irregularity and anovulation. There is androgen excess, multiple cysts in the ovary. So there are just clinical manifestations of PCOS, but the actual cause still remains under the shadow. In Indian PCOS, we find more of menstrual irregularity, more of anovulation, more of androgen excess, more of multiple cysts in the ovaries, and we find insulin resistance. Thus, for the management of PCOS, focus should be addressing not only T's and B's. You hit at the root cause. What is the root cause? Is insulin resistance. What is the most important anti-insulin resistant drug? Undoubtedly metformin. Therefore, the correction of insulin resistance subsequently improves the hyperandrogenism and endocrine parameters, and also improves the anovulatory cycle. So the central culprit is the decreased, what we showed now, decrease. So Indian PCOS can show two things. They can show metabolic complications. They can also reproductive dysfunction. Therefore, we must give a drug which will be double hit. It will take care of the metabolic complications like diabetes, little hypertension, little uremia-like thing, and also at the same time, take care of the infertility, take care of the scanty menstruation, take care of the psychological trauma the lady might have. So things like that, things like that. Therefore, dear friends, metformin as the number one drug for the females in the women's health, number one women's health drug, acts at each stage in women for PCOS by improving the insulin resistance, number one, with their menstrual irregularity. It improves menstrual regularity and hirsutism goes down. If there's an ovulatory cycle PCOS, it improves ovulation, increases pregnancy rate. PCOS or undergoing IVF prevents ovarian hyperstimulation syndrome, I told you twice before, and increases live birth rate. During pregnancy in PCOS, significantly reduces the miscarriage rate, reduces the risk of GDM, and metabolic dysfunction is improved in the form of improves dysglycemia and other metabolic functions. Therefore, metformin during ovulation induction with gonadotropins followed by timed intercourse or intrauterine insemination for subfertility is associated with polycystic ovary syndrome. Therefore, it is a wonderful drug. So metformin plus follicular stimulating hormone is associated with a higher cumulative live birth rate when compared to FSH alone in the female who is infertile. So metformin also a fertility induction agent, as I showed some time back. Now, it has been shown that metformin is associated with a higher ongoing pregnancy rate. You know that you saw the cartoon here, the flannel chart here. The metformin increases the fertility rate. And if you compare this metformin with the controls, you find that in all the studies from Begum to Erali, in all the studies, Colombo study, Tasdemir studies, increases metformin. The pregnancy rate increases metformin. That's a wonderful drug, therefore, dear friend. So therefore, metformin can be considered in women with PCOS who are already undergoing lifestyle treatment, and those who have impaired glucose tolerance, like pre-diabetes, those who have diabetes, etc. Now, if you look at the NICE guideline, which guides entire Europe, offer women with WHO group 2 anovulatory infertility who have a BMI of 30, even 30 BMI, to lose weight by one of the treatments like clomipene citrate. That is an ovulatory induction drug, but also treated with metformin, or better still, what we do, give a combination of metformin and clomipene citrate for the induction of the ovulation. So dear friends, as I told you, at every stage of PCOS, this works. Now, there's one publication which shows from Dr. Mishra that the effect of metformin in Asian Indian women with polycystic ovary syndrome, and you find significant improvement with the metformin in the Indian PCOS patients. Look, the fasting blood glucose has come down from 93 to 85. Insulin level has come down from hyperinsulinemia to 8.65, meaning the resistance is less. HOMA, the index, the insulin resistant index is less, and the Quickie index also shows it has come down. Therefore, metformin significantly reduces insulin resistance, normalizes LH by FS ratio, regulates menstrual cycle, and improves pregnancy rate in Asian women with PCOS, both in adolescence and in the reproductive age. Therefore, this part, let us conclude. We'll come back to questions at the end, which my friend Faraj is going to shoot it to me. Number one, in the Asian Indian women, there's early onset PCOS and early ovarian aging. Please remember, there's a high prevalence of the PCOS, higher fasting insulin and higher and low SHBG. Insulin resistance in more than 75 to 80% of the PCOS women. So we need strong insulin sensitizer as the need of the hour. Metformin improves insulin resistance, improves androgen level, improves menstrual irregularities, acne, hirsutism in all the groups. The last part of my talk is metformin pregnancy. Now, as you know, the prevalence of diabetes in pregnancy is rising. The GDM is exactly as the IGT in other conditions. And the prevalence, as I told you, is at least 15%. Some parts of South India, it is 17%. So pregnancy profoundly affects the management of diabetes. Placental hormones, growth factors, and cytokines cause a progressive increase in insulin resistance in the pregnancy, necessitating intensive insulin medical nutrition therapy and frequently adjusted insulin administration to prevent hyperglycemia dangerous to fetus. Now, diabetes in pregnancy can be pre-existing. A known lady with diabetes can become pregnant, can be type 1 or type 2, or lady can develop for the first time diabetes in pregnancy called GDM. There can be pre-existing diabetes or true GDM. Now, GDM defined as the glucose intolerance found for the first time during pregnancy, and after pregnancy over, that becomes normal. During 20 years, the prevalence has substantially increased in various ethnic populations. Increasing obesity has given rise to increasing GDM in our country. So there are a few factors. Maternal age, more than 25 years. Nowadays, girls marry late. Obesity is very universal today. Ethnicity, as South Asian, we are more prone. Family history of type 2 diabetes. We are a strong country with a lot of family history of diabetes. Previous IGT, previous glucose intolerance, and previous macrosomia. Now, for this GDM, metformin has stood out as a number 1 drug. I'll show the evidences from science. Before that, I would like to call it a wonder drug. It has got antimicrobial action on the gut microbiota. It has action on the cancer. I showed you breast cancer, endometrial cancer. I showed you it is a wonderful drug for the cancer. It has anti-aging. You can remain young. It takes care of the hair in unwanted part, hirsutism. It prevents precocious puberty. It takes care of the PCOS. It also takes care of the Alzheimer's, the mental retardation, the disease that is rocking the mankind today. It can be given along with radiotherapy for sensitizing the tumor, improving the side effects. It can take care of the atherosclerosis. It's a wonderful drug for a disease which is more prevalent in our country today, called non-alcoholic steatohepatitis or non-alcoholic fatty liver disease. It is a drug which is very important in this disease. It is a drug which reduces weight, so it can be used in obesity. And of course, for the gut, it prevents the lipogenesis, prevents cell proliferation. So extremely useful drug. Now, why it is used in GDM? I have shown this slide before. I'll again tell you it reduces weight gain, safe and efficient, and reduces risk of the miscarriage and reduces neonatal hypoglycemia. Now, it has been shown that when the women are treated with metformin during the first trimester, I have brought here that evidence goes way back in science for 50 years. The congenital malformations in offspring of diabetic women treated with oral hypoglycemic agent, that is that during embryogenesis. Now, 7 women were treated with metformin during the first trimester, and you find that the duration of exposure was quite good. Insulin treatment was not necessary in many of the cases. This study found is a negative study, no major congenital malformation in infants of diabetic women who are giving metformin. The proof of the pudding in taking it. Here is the proof that no major congenital abnormality was found with the metformin. No obvious indication was there for therapeutic abortion, meaning thereby it is quite safe even in early pregnancy. Now, today it is a contender, emerging contender for the metformin in GDM. Many RCTs have supported that the metformin outcome is very good. Ease of its use, acceptability by the patient, significantly less maternal weight gain and less maternal hypoglycemia are the points in favor of it. Now, the article from the BMJ, now you look at the systematic review and meta-analysis of the treatment for gestational diabetes mellitus in 42 studies of over 9,000 patients. You see that they were giving either insulin or metformin and glibenclamide. To make the long story short, I will not bother you. I've got only 16 minutes left. I'll leave behind 10 minutes for discussion. You'll find the metformin found to be most effective in reducing the risk of complications compared to insulin or glibenclamide. It was better than glibenclamide. We knew that, but it was also better than insulin. So today, metformin has stood the number 1 drug for the GDM. Now, if you look at the glycemic control between the metformin and insulin, you will find the glycemic control is very good. The post-treatment, pre and post-treatment of the glucose is equally good in both metformin and insulin. And the pre-treatment glucose level in the groups where metformin alone or metformin and insulin, you will find the metformin and insulin group, you will find is the group which are little higher hypoglycemia. So we combine. So all that means to say, metformin is the number one drug. The metformin does not work by giving 2 grams a day for about 1 week. You are giving 2 grams, it is not working. One can go to add insulin to it. It will have 3 advantages. Dose of insulin will be less, there will be less weight gain and much smoother control. That is shown here. The people who have little higher blood glucose levels, add low levels, both fasting, breakfast, after lunch, after dinner, we add insulin to metformin for the wonderful control. Again, I'll reiterate for GDM. So 21% of women using insulin and 27% of women using metformin achieved adequate control. In the first week, just you look at the wording, first week of the treatment, the control is very good in about over 1 in 5 patients. If you look at the newborn outcomes in women with GDM and treated with metformin or with insulin, you will find metformin is an excellent alternative to insulin. Insulin can be number one choice, those who want to take it, but an excellent alternative to insulin, the treatment of GDM with fewer complications to fetuses and better maternal acceptance. You look at the pregnancy outcome in the first trimester exposure to metformin, a meta-analysis, metformin treatment in the first trimester associated with a 57% protective effect. As I told you, it seals the embryo. On the basis of the data in this analysis, there is no evidence of an increased risk of major malfunctions, malformation, abortions, etc. with metformin when taken to the first trimester of pregnancy. And first trimester exposure to metformin is not associated with any major malformation, So metformin can cross placenta, but so what? Metformin was shown to be able to significantly cross placenta with fetal concentration in the range of half the maternal concentration. However, it does not stimulate insulin secretion or release and does not cause hypoglycemia. Metformin enhances insulin action, stimulates glucose uptake in the liver and also in the muscles in the periphery, and also suppresses hepatic glucose output. Meaning thereby that even though you give it even before the placental period, it does not produce any harm. So metformin also helps somebody to get pregnant. Metformin useful in the insulin resistance syndrome and constitutes increasingly popular treatment for polycystic ovary syndrome. Often, watch this word, it often helps in inducing ovulation and resulting in pregnancy. Metformin administration during pregnancy reduces the first trimester pregnancy losses in women with polycystic ovary syndrome. The first trimester pregnancy losses are prevented, and the early pregnancy loss is prevented. I show it here. Look at the history of miscarriage here. Look at with metformin and the placebo, 58.3% versus 11.1%. So it reduces the miscarriage, helps in getting pregnant, and prevents diabetes. There's a big study called MIG study, or metformin in pregnant study by Rowan. And this also has shown that in women with just GDM, metformin alone or in supplemental insulin is not associated with perinatal complication as compared with insulin. So the women who preferred metformin to insulin treatment can be given. It is quite safe. There's a study called MITI study, metformin in women with type 2 diabetes in pregnancy, MITY study, multi-center international randomized control trial at 25 centers in Canada, Australia, metformin versus placebo trial. Metformin has several maternal glycemic and neonatal adiposity benefit. I'll repeat again, several maternal glycemic and neonatal adiposity benefit. Therefore, women in the metformin group achieve better glycemic control and require less insulin. Women in the metformin group gain less overall weight and less weight per week. Few women in the metformin group had cesarean section, very important. Few women reported serious adverse events in the metformin group than the placebo group. No difference in women who received metformin or those receiving placebo in a study. So therefore, in large international population-based diabetes, no evidence was found of an overall increased risk of congenital anomalies after first trimester metformin exposure. So this is taken up now. The pregnancy outcome with the polycystic ovary syndrome, you will see that it improves pregnancy outcome. So what does the guidelines say? The National Institute of Health guidelines suggest metformin. I'll repeat again, NIH suggests metformin as the first line drug in GDM. ADA 2022, WHO, Australian Obstetric Society, all societies, they say that recommend use of metformin in setting for insulin administration has logistic or compliance issues. So guidelines are being modified today to include metformin as the more and more data is emerging. So the management from preconception to postnatal period, metformin is used in the NICE guideline, and it is #1 drug today. Dear friends, I must stop here to say that metformin is a great choice for GDM and pregnancy diabetes. Dear friends, I have tried to put before you the advantages of metformin and why you should use it, and the summary of evidence on the GDM, good safety profile, reduced rate of severe hypoglycemia, reduced pregnancy weight gain, and similar effect on newborn health. No difference in BP in the offspring, no difference in motor, social, or linguistic development. On fetal, no convincing effect of any bad effect on the fetus, and long-term health and the benefits are written large in the wall. Thank you very much for a patient hearing. Faraj, we can take some questions.
Thank you so much, sir. First of all, for giving your valuable time and sharing your knowledge with us and making this session informative one, sir. It was a really wonderful presentation and wonderful talk from your end.
Faraj,
I hope this talk knowledge is going to help all the participants who have joined this session on their practice also. Sir, I can see we have received some question from the participant, and if
yeah.
you allow, can I take these
Yes,
questions?
please.
Yeah, first question is from Dr. Anjali. She is asking, does metformin improve clinical features of polycystic ovarian syndrome?
Yes, Dr. Anjali. I know Dr. Anjali is from Pune. So what exactly it does? It reduces the hirsutism, the hair growth. You know, in the AIMS Delhi, we were not using metformin for a long time. Our drug of choice was spironolactone for hirsutism. But once metformin showed its effect on the hirsutism, the first clinical effect, the hirsutism goes away, having hair in the mush area. For the females, having hair on the cheeks goes away. It reduces the weight, so the obesity increases, and it helps in making the menstrual cycles more regular. So therefore, in all the three aspects that is visible outside, as I showed the tip of the iceberg, it improves. Below that, as I told you, metformin is an anti-metabolic drug, anti-vascular drug. So it is a good drug for the cardiovascular problem that can occur in the PCOS people. It is for dyslipidemia, it is good, and it is also good for the weight reduction. So it improves, Anjali, 360-degree of the clinical features in the PCOS.
Thank you so much, sir, for explaining it really well. I hope that Dr. Anjali has received his answer. I can see moving forward, sir, another question from Dr. Subramaniam.
Yes.
He's asking what can be the role of metformin for evolution induction in infertile patients?
Oh, it is a great role. You know, as I showed that there are two drugs, Dr. Subramaniam, in our armamentarium to induce ovulation. One is clomipin citrate, other is metformin. There is no third drug yet. Now, clomipin citrate definitely is the first choice. But you know, no drug is foolproof for all the patients. So there are some patients who are branded, as you know, quote unquote, resistant to clomipin citrate. In these patients, the metformin has produced ovulation induction and stood out large and clear. So it is a great drug for ovulation stimulation.
Thank you so much, sir, for once again answering it. Moving forward, I can see another question from Dr. Agarwal. He is asking when to stop metformin during pregnancy with PCOS.
That's a very great question. As I showed you that even though the guidelines say that you can start after 16 weeks because of the placenta, people have started it from the day one. And I belong to one of those groups. But the question that Dr. Agarwal has asked, when do you stop the drug? Now, it's a great question. Usually, we start with 500 BD. Now, during the mid trimester, the second trimester, the requirement of insulin is high. The requirement of anti-diabetic drug is high. We can go up to 1 gram BD if necessary. And usually, we stop the drug before the delivery because the requirement of anti-diabetic drugs comes down during labor and delivery. And people have also used this drug post-delivery because, you know, the GDM is a nature's experiment of preventing pre-diabetes going to diabetes. As I told you, GDM is nothing, but it is impaired glucose tolerance. When it is during non-pregnant state, we call it IGT. Pregnant state, we call it GDM. So what is the drug used for IGT to diabetes prevention? Metformin. So we also use this drug, Dr. Agarwal, in the postnatal period in a smaller dose, 250 milligram BD to 500 BD. No hypoglycemia will occur. It will prevent the GDM mother who is very much prone to pre-diabetes to diabetes.
Okay, thank you so much, sir, for answering all these questions. And I can see last question for today's session from Dr. Supridhi Sinha. She is asking, is it safe to use metformin during the times of pregnancy?
Absolutely a fabulous question, Dr. Supratik Sinha. I must tell you, I must assure you, in the Indian Ministry of Health guideline, in the guideline, NICE guideline, which is Europeans guideline, I showed you the guideline of WHO's two guideline. Guideline of the ADA 2022, the metformin is a safe drug. I'll give you another example, Supratik, to convince you. You know, for the PCOS, what the number one drug to be used? Metformin. And many of the PCOS people, while on metformin, become pregnant. And we do not stop metformin. You know it from your practice. We continue this. Forget about GDM. The prevalence of PCOS is 25 to 40%. Many of them are on metformin. All of them are on metformin. And they become pregnant after marriage. And when they become pregnant, they do not know in the first, nobody can know pregnant or not in the first month or even up to 6 weeks, 8 weeks. We continue metformin, nothing happens. And GDM study has shown it is totally safe.
Thank you so much, sir, for answering all the questions, sir. I hope that all the doubts of the participant has been clear. As I can see, there is no more questions. But one feedback from Dr. Jaiswal. He has written very good presentation. Thanks for this wonderful session, sir.
Thank you. Thank you. Thank
Yeah,
you,
sir. I think that Dr. Jaiswal has really enjoyed this session.
Thank
Sir,
you.
as there is no more questions, sir, with all your permission, shall we conclude this session?
Yes, yes. I think we'll conclude and we will produce such programs more and more with different experts. It
Okay,
is
sir.
greatly helpful. Thank you
Great,
very
sir.
much. That was the dream of my friend, Dr. K.K. Agarwal. And
Great,
that's
sir.
the
Great, sir.
dream of Nilesh ji. You know, we become richer by sharing the knowledge. If you share money,
Exactly, sir.
or anything else. So sharing knowledge must continue with this hope.
Exactly, sir.
With my sincere thanks to IGCP Group, to all of you, Faraz, and all your colleagues, Nitish and all that, Nilesh and all that. I take leave of you. Thank you. Thank you.
Yes, sir. That's all our great pleasure to have doctors like you, sir. So because of you only, we are able to share the good knowledge to the different parts of the country where the knowledge is also not available, sir, like as well as rural areas also, sir. And hope to continue this share of knowledge, sir, in coming times with you, sir. Until then, take care of yourself.